I'd like to turn the podium over to Dr. Jason Lee to introduce our invited speaker on the very important topic of implicit bias.
Thank you, Dr. Shames, and I wanted to echo a lot of his sentiment, and thanks for allowing us to spend this afternoon with you for the APDVS spring meeting. This year, the themes were related to trainee feedback and assessment, as well as recruitment of trainees. When we thought of how we could have a keynote address that tied that all together, given all of the events that have occurred this past year and for centuries, really, we wanted to have a discussion about implicit bias. As we, the program committee, thought about who could help us with this, Marnie Grambo was top on my list. I've known Marnie for the 5 or 6 years that I've helped with being a volunteer first for writing board exam questions. And now Marnie is the director of development of exams for the Vascular Surgery Board and the American Board of Surgery. She's been helpful in designing and implementing things related to resident and fellow education, certification, and maintenance of certification of all surgeons. She has developed such assessments, standards, and advised the American Board of Surgery, the Vascular Surgery Board, on all of these things, including various innovations over the past 15 years. She's also collaborated closely with the American Board of Internal Medicine and really is a thought leader in terms of the American Board of Surgery on these types of ideas. Most recently, she's really focused on EPAs, which we also will speak about later this afternoon. And based on this morning's session, probably is something that we're going to continue to hear about over the next many years. So to tie in trainee assessment, feedback, and trainee recruitment, we felt that having a discussion about implicit bias would be perfect for this. The title of Marnie's talk this afternoon is Rainy Days and Resumes, Mitigating Implicit Bias in Clinician Assessment. And with that, I'll turn it over to Ms. Grambo. Thanks, Marnie, for participating this morning.
Thank you so much, Dr. Lee, Dr. Shames, for inviting me to be here today. I'm so pleased to be at the APDVS meeting speaking to you about implicit bias.
Just click anywhere on the actual slide surface with your mouse.
Gotcha, thank you.
You're all set.
Well, that was a disclosure that said I basically have nothing to disclose other than I'm staff at the American Board of Surgery. Sadly, no commercial relationships. So what is implicit bias, or what some people call unconscious bias? It's not this. This is much easier to see. Implicit bias really hides from us. It's much harder to see what our own implicit biases are. And so when we talk about implicit bias, we're talking about the dual systems theory of cognition. And this is an image I'm borrowing from the Curran Institute for the Study of Race and Ethnicity at The Ohio State, but this is something that you may also have heard of from Daniel Kahneman's Thinking Fast and Slow. So the system one part of our brain is that fast thinking system. There's, muscle memory and heuristics and all sorts of things in here. This is the part of your brain that automatically drives your car home at the end of the workday, even though you meant to stop somewhere on the way. I mean, that's an incredibly complex set of mechanics that you have to manage to be able to do that, and you can do it paying very little attention sometimes. So it's a very strong and important part of your brain, part of everyone's brain, and part of how we're wired. System two thinking is effortful, but it's thoughtful. And this is the part of the brain where we can mitigate implicit bias. The system one thinking is where implicit bias lives. be biased is to be human. So we actually all do hold implicit biases. That is just, again, how we are wired. And our unconscious biases may be completely misaligned with our own personal values. And just because you are aware of different stereotypes doesn't mean that you believe in them, but they still take up some space in your brain. And it's easy to accept some biases, halo effect, confirmation bias. We're more familiar with these things, but this is challenging in the STEM community, particularly amongst doctors, when you're so highly educated and scientifically minded and data driven. It can be very difficult to see yourself as biased, which in itself is its own bias, the bias blind spot. And just unfortunately, Lake Wobegon, where all the children are above average, mathematically exists only in Garrison Keillor's head. It can't exist in reality. In one survey, 97.2% of judges rank themselves above the median judge in avoiding racial bias in making decisions. And of course, judges' decisions can be critically important, just as yours can be as well. So what does the evidence tell us? And we'll run through it in this presentation. So implicit biases actually often correlate with behavior, and that is especially as compared to self-reported or more explicit conscious biases. That is for a number of reasons, including, when you don't have awareness of them, it's very hard to own that and be aware that you have that bias. And also there's a lot of shame involved. No one wants to get up in front of a group of people and say, I am sexist, I am racist. And so I will do that. I will be the first one and you can join me. I am sexist, I am racist. I have all sorts of biases in my head that don't align with my own personal values, but probably affect me on a day-to-day basis much more than I would like them to. But how much they affect you can vary, and it really depends on environmental factors and priming. And so there are things that we can do to mitigate bias. So talking more about some of the foundational ways that our brains work, humans have a deep-seated need to identify like others and unlike others, in-group and out-group. And this always appears like we're breaking something into a binary categorization here, black and white. But as we know, there's all sorts of gray area. And so anytime you try to break something into in-group, out-group, there's this liminal threshold group that's between and betwixt these two groups that is sort of both and neither. And individuals who exist in that kind of space sometimes have biases against them from both groups. They're a little bit in everybody's out group. That is a particularly difficult space to inhabit. And that can be compounded by other biases, as we know from intersectionality and just the additive or perhaps it's multiplicative effect of different biases aligning. The origin of us versus them, in-group and out-group. This is a study out of the Yale Infant Cognition Center, and they took pre-linguistic infants. They were still pretty much able to figure out what the infants were communicating, but this is before they had language, before they had been taught prejudices and cultural norms, and they presented these infants with a choice of snack, green beans or graham crackers. And once the baby ate the snack, that experimenter would leave and somebody else would come back in with these puppets, orange lamb and yellow lamb. And the lamb puppets would eat the same snacks. And one of the lambs would agree with the infant, yum, 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 yum. I like green beans too. And the other puppet would disagree with the infant. Green beans, yuck. I like graham crackers. That experimenter left the room and another experimenter came in, totally blinded to, what the child had eaten, what the puppets had eaten, and offered the puppets to the children to play with. 80% of the time, they chose the puppet that liked the same food. So these infants are finding their peer group, they're finding their like others in even very trivial likenesses. Environmental factors. So this is a study out of the University of Toronto. They looked at their medical school interviews between 2004 and 2009, and after adjusting for every other parameter, they realized that the candidates who interviewed on rainy, overcast, gray, cloudy, awful, yucky days received about a 1% lower score than those interviewed on sunny days. And all told, that factored out to be equivalent to about a 10% lower MCAT score. And it's a 1% lower score. How much could that affect anyone or anything? Well, every single one of those years, there were about 100 students that fell within 1% of the admissions threshold. And again, when we talk about intersectionality, if your mood is affecting how objective you can be in your assessments, how does that then combine with additional biases? And so it's very common to talk about gender bias, race and ethnicity bias, but there are so many different things that go into your ability to stay in that system 2 thinking and not revert to system 1 thinking, and to stay as objective as possible. This is a study out of STEM, so this is lab manager applications. This is the resumes to our rainy days. So there was a fake application, a single application identified as either a male student or a female student. They were sent to professors in biology, chemistry, and physics to be lab managers. And the professors were asked to evaluate their competence, their hireability, and whether or not they would offer them mentoring, and then what they might want their starting salary to be. These dark gray bars are the male name on the resume, and the light gray bars are the female name on the resume. And so all of the professors rated the males as more competent, more hireable, they were more likely to mentor them, and they wanted to offer them more money. Female faculty did not vary. You can have implicit biases against your own in-group. A lot of implicit biases come from stereotypes, archetypes, gender schemas, and gender norms, and so we share a lot of our implicit biases, even when they are negative towards ourselves. They also found that the professor's scientific field, age, and tenure status had no effect. So this was common for the professors that had been at it for a while and for the newer professors. There was a study out of, there's about 22 different law firms and 60 different law partners were asked to evaluate a legal memo written by Thomas Meyer. Similar to our last study, what we see in this study is that the Caucasian Thomas Meyer, having written the same legal memo, the Caucasian Thomas Meyer was evaluated as generally a good writer, has potential, good analytical skills. However, if the same memo had been written by an African-American Thomas Meyer, needs a lot of work, can't believe he went to NYU, average at best. And again, this is not one law firm, this is almost 24 different law firms. So this is an activity for you to do at home. You can you can conjure an image in your head. You can come up with a stereotype or an archetype if you're prompted to do so. So just let your mind wander and fill in the blank in your mind. What does something look like? What about an astronaut? What does an astronaut look like? And listen, maybe you're a big fan of John Glenn. Maybe Sally Ride was your hero. It's not wrong to picture a white astronaut or a white man. How many of you would picture Jose Hernandez? So this is an individual who worked alongside his family as an itinerant farm worker, harvesting crops, moving from one town to another in California and Mexico. He attended a number of different schools. He didn't learn how to speak English until he was 12 years old. And in thinking about your pipeline, if you met him at 10, not speaking any English, aspiring to NASA, would you encourage that dream? By the way, Netflix is currently working on a movie about Jose Hernandez. So the next time I present this slide, you might actually be picturing him, which would be wonderful. And that's part of why representation matters so much. So what about a fan of Star Trek? Can you picture the sort of the classic stereotype? Or perhaps you're just picturing me because this is my slide set. But would you picture Lucille Ball? She is the reason we have Star Trek. It was her production studio, Desilu Productions, that funded it. And she personally greenlit the project. She actually ended up selling the production studio in order to keep it funded. The Dallas Cowboys cheerleader. That's a pretty iconic outfit. Personally, I'm picturing Robin Williams, but I'm sure you all have your own cheerleader in mind. And is that person Nicole Bush, who is a pediatric urologist and a surgeon? Do you picture a cheerleader when you think of a surgeon? Do you picture a surgeon when you think of a cheerleader? What does a surgeon look like? It's not that anyone can be a great surgeon, it's that a great surgeon can be anyone. And so we have a tweet here from Mary Brandt. What is the collective term for a group of women surgeons? Surgeons, they're just surgeons. And again, so representation really matters in breaking some of those stereotypes, breaking some of those assumptions, and picking apart some of those implicit biases so they're not so powerful. So implicit bias has an impact on doctors. We know this has been published for many years. Black and Asian medical students are less likely to be AOA members. Black applicants are 10 percentage points less likely than whites to be awarded NIH research funding. Women are less successful than men in renewing their NIH grants. They are also underrepresented as academic grand round speakers and as conference speakers. And a few years ago, the Association for Women Surgeons put out a statement on gender salary equity and said that after adjusting for variables that could impact salary, women in surgical subspecialties earn roughly $44,000 less than comparable men in the field. And that's a very big impact. Let's talk about the implicit association test. I've been talking a lot about how you are biased and I am biased and we all have biases, but how can we know what they are? If they're unconscious, how do we make them conscious? And that is where the implicit association test comes in. And it's free. You can complete as many of these as you like. It's aggregated for study, but anonymous when you do it. And I really encourage all of you to give it a try. And so what you see here are some of the topics. There are many topics on the website. And the way that it works is it presents you with different images or words and asks you to make a quick association by hitting a key on the keyboard. So for instance, there's an implicit association test of how closely, how easily you associate women with the family sphere and men in the workplace. And so on either side of your screen, things will pop up. And if it's, men, it's on one side. If it's women, it's on the other side. They switch it back and forth so that it accommodates handedness as well. And basically, it measures the time it takes to make a correct connection. If you are struggling to make the connection, if the association that you have isn't really strong, it'll take you a little bit longer to get there, or you might make a mistake. Think of it as if I say peanut butter, it might be very easy for you to say jelly, but if I ask you to say tuna fish, when I say peanut butter, that might not be just quite as automatic right at the tip of your tongue. And so it really helps people to get a better understanding of their own thought process. So does implicit bias predict behavior? Yes and no. Let's talk about it. So this is a study that looked at a group of physicians, and these are fake patients, but similarly to the past study, we have some who are white, some who are black. They all have coronary artery disease. So the doctors in this study completed implicit association tests to see if they had a pro-white or anti-black bias. They were also asked explicitly, do you have any bias? None of them self-reported a bias. Again, they were either unaware or there's a tremendous amount of shame about admitting that you might be biased. And so this is not something that people easily admit. Claiming that, no doctors are biased, we see their IAT results and realize that of course they are. And what was seen in this experiment was that as the doctors pro-white implicit bias increased, the higher their pro-white anti-black bias increased, the higher the likelihood that they would treat their white patients with thrombolysis, and the lower the likelihood that they would treat their black patients with thrombolysis. And so, whatever they may say about their biases, their behavior tells us something different. But this is not a trap. We are not stuck here. There was an outlier group of 67 participants who were not included in all of that aggregate data because they didn't follow that pattern. They were physicians who were aware of the purpose of the study. They were aware of their IAT results, and when they had an increase in their bias in favor of white patients, they were actually more likely to offer thrombolytic therapy to their black patients. So we've seen here, and actually we see this in other studies, that having an awareness of your own biases can really help you to mitigate them. So what can we do about it? Well, the first thing that we can do is accept that we can mitigate implicit bias, but not necessarily eradicate it. Again, this is how our brains function. So we have to enter every situation just assuming that everyone is biased. And so there are both personal and structural strategies that I'm going to recommend to support objective decision making. And it's also really important to keep the momentum and to stay alert for opportunities for progress. There was a lot of discussion around women's rights and sexism around the Me Too movement. There's been a lot of discussion of, racism with the Black Lives Matter movement. We're now seeing that in the Asian American Pacific Islander population. They're having their moment. We're talking about it, but the news cycles move away from these things, but if we want to make progress, we have to stay here. This isn't a one and done conversation. We don't patch things up and move on. There's really a lot we need to continue to do all the time. So on a personal level, what can you do? Again, take the implicit association test. It's really important to have an understanding of what your implicit biases are. That can help you with your self-awareness and introspection. You want to prime yourself before you put yourself in a situation where you're going to be interviewing a candidate or speaking with a trainee. Remind yourself and any others of the shared values of being fair and equitable before beginning any kind of evaluation. You want to support your system to thinking. This is all the things that you think it is. Stay comfortable, well-fed, hydrated, caffeinated if that is your thing. Make sure that there are no distractions and that you are able to maintain that really effortful space for a period of time. For those of you who have served as examiners for the board's oral exams, you know how incredibly exhausting it is at the end of the day, having just sat the whole time, but the effort of your brain to be following the cases and following the candidate and making sure you're listening and grading appropriately, it takes a lot out of you. And expect that it's going to. Plan accordingly. Mindfulness meditation is really interesting. It has been shown to reduce biases. One way to think of implicit bias is as a habit of mind. That's that system one. It's a habit. It's your car having the habit to drive itself home. It is falling into stereotype assumptions. And mindfulness meditation is a great way to focus on the thoughts that you're having and see them as a mental process, something that your brain is doing, but separate from you yourself. You can look at your thoughts and let them float away. You can look at them and disagree with them. You can analyze them in a non-judgmental way, and that really has been shown to reduce individuals' implicit biases. You can also increase opportunities for contact and search out counter-stereotypic imaging. But how and who? So that is also where the IAT comes in. If you know that you hold a specific implicit bias, then you have the information, the tools you need to really counteract those biases. So searching out a counter-stereotypic image for a lot of people, that was Barack Obama a few years ago, just looking at, powerful, smart, well-educated, successful Black man did a lot for, breaking those kinds of stereotypes that are really all over our country. And search out contact, break the stereotypes by learning about individuals. They also say that perspective taking and individuation, just acknowledging that this is an individual and not a part of a group, can also help prime you to be more in that system 2 part of your brain. Structurally, there are a lot of things that we can do too. This is really not on any one person. And again, these are structural recommendations for mitigating implicit bias and not structural racism, not explicit bias. There are a lot of other issues. There's the leaky pipeline issue, but these are specific recommendations for mitigating implicit bias in your interviews and training evaluations. So shining a bright light on it. So what we're doing right now, bias training, discussing bias, revisiting it later, not losing the momentum. And then you want to be as methodical and data-driven as possible. So you want to determine evaluation standards in advance and ensure that all evaluators use them and hold all candidates or trainees to the same standard. So that's, if you have you know, a white woman applying from inside your program and a black man applying from outside your program, you wouldn't give him an exam because you don't know him and then just assume she can do it because you do know her. Compare those apples to apples. You know, everybody should be undergoing the same evaluation, being held against the same standards. Now that can be difficult for groups that have historically been the victims of bias and prejudice. And, you know, when you talk about comparing, for instance, CVs and thinking about the lab managers, whether someone was mentored, whether they were hired as a lab manager at all, if we see that as being affected by bias, we have to really consider whether that is something that we want to use as part of the vetting process. And so that's actually my last bullet point here. Make sure that the qualities that you are evaluating for matter for the decision at hand. Earlier in the process, before you are face-to-face, consider redacting candidate details so you don't know if you're going to be interviewing you know, a man or a woman. Also really important to record the thought process behind your decision-making. You know, write out why you've evaluated someone in a certain way and not in another way. And have transparency in the appropriate context. So not with the candidate necessarily, but with the other evaluators or interviewers, you know, explain to them your reason for, you know, liking this person or rejecting them, and have them explain to you. That can really prompt us to stay in our system to thinking and keep us really thoughtful. Make sure that there's data behind those kinds of decisions. And then be detailed and specific when you're coming up with those, you know, rubrics and credentials and things that you're looking for. Provides appropriate care. Well, what is appropriate care? Implicit bias lives in these dark, shadowy spaces of imprecise language. Lay out exactly what you're looking for. It's also great to have multiple people making decisions. Really great to have decision-making bodies, and make sure there's heterogeneity among decision-making bodies. Even though we share many of the same implicit biases, we don't share the same upbringing or context or life experiences, and you know, we will understand things differently when we hear from other people with different perspectives. And then audit your process, find out how you're doing. And that's a multi-step approach in that you really have to know that you want to audit the process and collect sufficient data to do so. You know, come up with your questions ahead of time and make sure that you can answer them. And you don't assume that you're making a change because you want to make a change and you've made that decision. Because it's really hard to change what you haven't measured. You should really confirm. And so one of the things I'm particularly excited about is what I call the promise of EPAs. And sort of teeing up your afternoon, I'm sort of teeing up Tom Huber here. But I think that entrustable professional activities are incredibly promising for offering structural support to mitigate implicit bias and to keep people in the system to thinking. So why do I think that? There's complete transparency with the trainees. There's a description for each level of entrustability, and the assessor observes them and rates them at a specific level and explains, this is why I put you at level 3 and not at level 4. Here's the gap. This is what you should do to be at level 4 next time. So the expectations are explicit, the evaluations are against a detailed shared rubric decided upon ahead of time, and all of the decisions are really based on data and actual observations. Like having a a large decision-making body, we end up getting a large aggregated number of assessments, which can help with bias. And then the observations themselves are collected from a diverse group of observers. And this is just a hypothesis of mine that the EPAs are actually going to push the envelope on implicit bias, but there is some early pre-publication information with JAMA surgery. And so watch for that. I do think there's some early data to support my hypothesis that EPAs really offer a more objective assessment for trainees. All right. I think I am running a little ahead of time, but plenty of time for Q&A.
Okay. That was wonderful, Marnie. Thank you for going through that. I've probably heard this 3 or 4 times now, and each time you've certainly provided a twist and some new things for me to think about. Rebecca or Pete, can you turn on my video? It's not letting me turn it on. There it is. Okay. There's going to be a lot of questions on the chat. We're monitoring that from here. So we'll just start asking some questions. I wanted to start with just kind of a general disclosure question for you, Marnie. Have you taken an implicit bias test, and what were those results, and how do you think that colors giving a talk about implicit bias?
Oh, thank you. I have. I've taken 2 implicit bias tests that I think would be helpful for this conversation. So the first was associating Indigenous Americans with America versus white Americans with America. And my results were that I was pretty much not biased at all, and I got to feel really smug and self-satisfied for a while. And then I took the IAT that associates women and the family sphere and men in the workplace, and I am so profoundly, incredibly biased against women in the workspace and men at home. And that threw me. My career is very important to me. I'm working at the Board of Surgery. Our leadership is Dr. Joe Beiske, of course, is our president and CEO. I was there under the leadership of Mary Klingensmith as the chair of the board. I had many opportunities to collaborate with Vivian Gatton as the chair of the Vascular Surgery Board. My 76-year-old mother is still in the workforce. She's a therapist offering video-based therapy during COVID time. She's busier than ever. I have no shortage of wonderful female role models, but because of my upbringing, I have a really hard time associating men with the family sphere. And so that is where the other side of the coin comes in. When you're taking these tests, you're making associations at both ends of the spectrum. And so you don't necessarily have to be anti-woman to find yourself marked as extremely biased against women, so long as there's something going on with your feelings about men. So that I think is really interesting, and it represents a bias blind spot that I have. And I do have a young man on my staff who reports to me. It's really important for me to know that I have this bias blind spot around men and family life. He might want to start a family at some point, and what if he came to me to negotiate his time off? How much time would I think to give him? And that is where the structural solution comes in, where that will never happen. It's not up to me. The board has a parental leave policy, not a maternity leave policy. And so they've already put out there, what their expectations are for the treatment of men and women when they become parents. And they've, done a lot to make that as equitable as possible. So I think knowing how incredibly biased I am against myself has really helped me come to terms with how biased we really all are. And it makes it easier for me to stand up here and say that I have implicit, racist attitudes and probably every other, ism out there, because I was raised in the US and those stereotypes are out there. And there's, like I said earlier, there's a lot of shame when it comes to discussing this. It can be very hard to discuss things from a position of power, and that stops progress. We all have to own up to being human.
Thanks for your open and honesty with that. Murray?
Thanks, Marty. That was fantastic. And I learned a lot, and I've done this before. So I think we're all extremely biased in our own way, and have to figure out a way to overcome it. And so one of the things we had talked about earlier, and I think comes up often in academic surgery and in certainly recruitment, is what value to put in. And you kind of addressed it towards the end, and sort of maybe getting rid of the paperwork and not having the CV available when you meet with the people. But we all put a lot of sort of value on the types of education that people have. Did they attend the Ivy League? And and I have a bias, I can admit that. Like, it was really hard. It takes a lot to get in, and I think having college-age kids right now applying to college, and I see how hard it is to get into college. Why not value that? Why not make that important? But we're really like having to look at all different types of people, and some of that, some of it going to the Ivy League is a privilege thing. Can you afford to go? Can you get in? Can you, do the work that's necessary? Do you have the opportunity? And so we're trying to look at ways to mitigate that, but it's out there. And, those people who have gone to those institutions, I think would feel like they're not getting the value anymore. And so how do you address that? Or how should we address that?
Yeah. Thank you. Great question. So there are a lot of qualities inherent in, Ivy League educated, elite, different descriptors, like thinking of an astronaut, you can say, Harvard, Princeton, Yale, and come up with an image of a person, an idea of a person. And when you think of your ideal candidate of a vascular surgeon, there's probably a lot of overlap with how motivated and hardworking and smart they are. But the university stands for those things, but doesn't guarantee those things. It's a placeholder for those qualities. And as we know, not 100%, not every person who graduates from a program like that is going to meet the standards that you have for vascular surgeon. And on the other side of that same coin, it's a non-zero percentage of people who went to other universities who are going to fulfill those requirements and meet those qualities. And so I think it comes down to identifying those qualities, coming up with those basic things that are critically important, and measuring those, looking for those, asking about those, rather than replacing it with something that means the same thing. So rather than a Stanford degree, you have a list of things that you're looking for with how they conduct themselves in the interview, how they conduct themselves with patients, whatever it is that you think are actually critically important, make sure that's what you're assessing people on.
Jason?
I thought that I'd summarize Dr. Tonneson and Dr. Trecci's questions together. we wind up relying on a system of getting letters of recommendations from our peers as we go through the assessment and recruitment process to get new students and residents into our residencies and fellowships. What are your thoughts, Marnie, about having more of a standardized way to do that? Standardized letters of recommendation, or balancing the idea that we're just checking off a checklist in terms of what we're looking for, rather than sometimes some of the personal touch that comes with a letter of recommendation, while still preserving some of that valuable information that is in there, maybe in between. People talk about reading in between the lines of, this person really would fit in at Stanford or something like that. We as evaluators struggle with that, and I'm curious your thoughts about how maybe some tangible suggestions to find the common ground that maybe as an organization, the APDVS could say, this might be best practices for future letters of recommendation to mitigate implicit bias.
Yeah, great. I think a checklist is a wonderful idea. Again, I think a shared list of criteria so that people are assessed the same way on the same things. I think making it clear ahead of time, potentially even publishing, what's on the checklist, so that people who are interested in pursuing this pathway have that in mind as their goal. And it becomes something achievable. Again, you want to make sure that you're comparing apples to apples. So, someone might have a beautifully written recommendation letter because it was written by someone who's a fantastic writer, and somebody else may have a really short, tepid, matter-of-fact letter that doesn't inspire you in the same way, but they might even be a better surgeon. There's so many different factors that go into that that are really very subjective and at the whims of all the previous structures, which of course is the other issue with the sort of Ivy League education, is the who's in that pipeline. So I think the letters of recommendation also may or may not all speak to the same points that you're looking for. The checklist would do that. So I think, the more detail you can have about what you're looking for, what the expectations are, the more transparent you can be. I think that really, shines a light in some of those dark places. Anytime that you are pretty transparent, other people can also keep an eye on what's going on, audit the process, check the decision making, check to make sure that people actually are being assessed in a way that's comparable. To some extent, it's never going to be comparable. Again, not every day is a sunny day, but I think anything that we can do to make sure that our comparisons are fair, it would be really reasonable.
Most every day is sunny in California. Go ahead, Murray.
I was going to say that about Florida, but we have a lot of sunny days.
Yeah, I'm calling in from Philadelphia, and yet it's not always sunny in Philadelphia.
It's not sunny in Chicago, I can tell you that. We have a bunch of questions. Dr. Amy Reed asked, tips to help increase awareness of bias in semi-hostile areas such as the OR, where trainees and faculty are often not well fed, rested, hydrated, etc.
So I think that would be great for priming. That can be some of your, timeout and checklist to, before you enter the OR, before you begin the surgery, talk about your shared values of being respectful to each other and, treating each other carefully and kindly, and making it a conversation that people are having. It's so hard to talk about these things, and the only way it gets easier is to talk about them. Another really important piece is on the back end in terms of protecting people who feel vulnerable. Often existing methods of complaint don't really support underrepresented people or don't necessarily understand the situation that they're in. So looking for structural ways to support people who may be in you know, a more difficult situation and giving them a way to be heard. I did just read the other day that there's an association, there's a correlation between microaggressions and physician burnout. And women and underrepresented minorities who were subject to a greater number of microaggressions had greater rates of burnout. And so it's really important to pay attention to these things.
There's an interesting question from Mark Matos from Michigan. Should vascular applicants take the implicit bias exam, and should these results perhaps be part of the interview process? Or maybe I'll take a different tack, vice versa. Should we be more open as faculty and interviewers as take these and make that maybe in an aggregate way available to the applicants?
Yeah, I think that's more reasonable than asking the applicants to take the implicit bias test, in part because of what we saw with the outlier group. You know, if I were judged by my IAT results, I would be very embarrassed. But I don't think that's actually how I perform professionally in all situations. And so I think, you know, knowing that people can overcome their biases, hang that around their neck to be part of their evaluation is not the best idea. But certainly the people who are evaluating them should be aware of what biases they're bringing to the process, whether it's, you know, their education or weight or gender or height, or there's so many, you know, different things that play into it. I think understanding that and talking about a transparency with the other evaluators, you know, going in if there's an interview panel to say, you know, I'm pretty biased against you know, women in the workforce, or I'm, you know, biased in favor of men in the workforce, or, you know, however you want to phrase it. So please check me. Please make sure that you're watching me. But I think, again, you know, we don't want to use the IAT as a cudgel or a punishment. We want to use it as a tool to understand ourselves better and to fix things.
We have I think a little more time, and we have a ton of great questions. So I'm going to put two out, and you could potentially answer them both. If these biases are this is from Dr. Paul Perkowski. If these biases are unconscious and disassociated from our value systems, why is it so uncomfortable for people to discuss them with respect to themselves? And then Dr. Gabby Velasquez asked, how do you get your partners to be more patient and aware of their implicit bias when they may be reluctant to take training, especially during the recruitment interview process? So how do we get, I guess, I put them together, so how do we talk about this amongst ourselves and identify, I mean, you were very forthcoming with what you think your biases are, and then how do we get to overcome that by, you know, talking about it openly and making it not a bias that we then use to make decisions?
Yeah. I think it's really hard in our culture to be called a racist or a sexist. We don't want to be bad people. You know, doctors have all taken the Hippocratic Oath. You don't want to hurt anyone. And it's hard to accept that your behaviors might do that. And I think, you know, one of the ways to approach that is to really talk about it from the perspective of bias being part of how our brains work, and being biased against ourselves as well as against others, and how it's it's a universal experience that we share, and it doesn't make you a bad person, it just makes you a person. And it is distinct from actually explicitly having biases and prejudices and going out of your way to commit certain acts. Having implicit racial bias is not necessarily the same thing in the way that we think of the definition of it as being racist. And I don't know that it's well known enough for people to be comfortable having that conversation. And so I think, the more people who can talk about it, write about it, think about it, discuss it casually, discuss it formally, if there are, other department meetings or initiatives where you can bring up a suggestion for the entire department to look into the implicit association test, or looking into, some of the studies that I pulled that are just a little more gentle for convincing people that implicit bias is real. I think the Yale infant cognition experiment was really interesting in a very non-judgmental way. And when people feel judged, they shut down. And so, it might be a little bit of a constructive criticism compliment sandwich, right, of saying something positive and encouraging, but also explicitly saying this is something that we should be, aware of, thinking about, trying to work on. I don't know, how you can make it a bigger initiative if you don't have leadership's buy-in. So I'm not sure I have advice for that, but I would love to see leadership everywhere having buy-in, and facilitating having these discussions. When you have people in leadership positions who are, denying the existence of implicit bias or their own biases, that hurts us all. And there's a lot of great literature out there about how it is real. I'm actually going to follow this up with a list of suggested readings, and I'll give you all of the citations from my presentation, and you can feel free to share those as well. My slides are going to be available. You are all welcome to take them apart, put them back together into your own presentation, and talk about it. Talk about it at grand rounds. Just find opportunities to talk about it.
No, that's very helpful, Marnie, to share a lot of that. And I think this group, as folks that are very invested in shepherding the next generation of vascular surgeons, sees and hears this loud and clear. There's a question from the chat about allyship, and how do we really show the candidates that we're not living their lives right now. They're anywhere from 5 to, or probably 8 to 30 years younger than us. How do we show these candidates that are applying that probably feel impacted by some things related to implicit bias, that we're actually allies and that we're thinking about it? You probably think or see this in the same role from the examination side of things, that we want to assure examinees that we, as say the Vascular Surgery Board, the American Board of Surgery, are thinking about this. So how should we as the APDVS also reassure candidates out there that this is an important thing?
Well, in terms of the setting, just to start with the idea of meeting with these young people in person or by video, if there are images that you can display that look like them, if you have, even if they're stock photos, if they can see themselves being a vascular surgeon, they are more likely to feel welcome. There's really good evidence that stereotype threat changes how people perform. So for instance, women or girls who are reminded of the stereotype that they aren't good at math right before a math exam will perform more poorly than they would have otherwise, and as compared to cohort groups that don't receive the same stereotype threat. So I think being really aware of how you come across, how you're presenting yourself, your organization, your department, how inclusive you appear to be or want to be really matters. When it comes to the Board of Surgery, one thing we did with the general surgery oral exams, we recruited a pool of examiners who matched the demographics of our candidate pool more than the demographics of our current board leadership. And that's not always possible. Generationally, you don't always have that kind of representation in leadership levels. But I think, looking for opportunity for people who are underrepresented in leadership positions to get into those leadership positions, to share some of the leadership load, not necessarily a leadership position, but those decision-making bodies. How many people are on them? How many committees do you have? How many opportunities do you have for, new blood, fresh perspective, people to come in and share their thoughts on things? The more diverse a perspective you can get, the better. More understanding you'll be for where candidates are coming from and what might be going on in their lives. I think, putting out statements, position statements, white papers, I think, inviting me to give this talk, I think is great for APDVS. Wonderful, and thank you again. It's a really public statement that you care about this, and the more you can do that, the more that message will be received.
That's great. There's some questions in the chat about can you speak a little more about blinding applications? How much is enough to mitigate bias, but too much to account for the fact that certain students may have had equal access to research opportunities, mentorship, and education? And then a response from Bridget Smith, that was from Beth Blazek, is regarding blinding the applications. It is interesting that in some of the research presented, if we're aware of our biases, we do well at overcoming them. So maybe we shouldn't unblind them.
So I was recommending that for very early stages of evaluation, at the reading the CV level. I think it can be helpful to potentially have two sets of reviewers, a blinded set of reviewers and a set who are aware of the names and maybe demographic information of the candidates, and see if there's a difference. Again, auditing the process is very, very helpful. If you have an idea for an improvement, try it out, see if it makes a difference. It's really worth it to try it. But I think that there's an important balance in there in terms of the opportunities for access. So besides doing what we can to improve opportunities, distilling the decision down to the most critical aspects can become more important. So it may not be how many publications they have, it may be what they're publishing on, things like that. The other thing I would say is, gosh, what did I want to say? just that, nope, that was it. The thought is gone.
I'll follow up with kind of how we've done the blinded versus unblinded. We're fortunate to have a lot of volunteerism during the interview day, and actually about half of our faculty have already looked at the applications to do the screening, and so we do know a lot about their scores, et cetera. But we leave a handful of faculty that are part of the review session totally blinded, as if they just met the person for the first time. And in our ranking session after, as we talk about the candidates, a lot of things come up that the room that knew their CV couldn't glean from a conversation, as if you were meeting over a meal or something like that. So I think there are some interesting ways to do that if you have the bandwidth, people-wise.
Yeah. So there's some research around the unstructured interview, which again, where anything is imprecise is where implicit bias can kind of sneak in. So, having a predetermined list of questions or criteria would help that process. And a few decades ago, I want to say this was maybe in the 1970s, there's a medical school in Texas that was asked to increase its class size by another 50. And they took in 50 students who had made it through to the point of the interview and been rejected because of the unstructured interview. When they were subsequently admitted, every measurement of their success and ability once in medical school was basically identical to the initial cohort that was accepted through the interview process. So I think we also have to think about taking a look at the data and having an honest talk with ourselves about how much we are actually learning from the interview process and how much that information matters. And so I did find my thought from before, which is you can consider also a weighting process where, yes, absolutely, if someone has, a dozen publications, we want to credit them with that, but it would never be the deciding factor. And so, different elements of an application may be weighed very differently so that you can still take those pieces into account without them swaying the entire decision to too much of a degree.
No, I think that's a great way to think about it, a weighted score, if you will. And I think each institution on the call is going to do that differently, obviously based on their experience, what their strengths are for their own individual program. Well, this was amazing. I think we could go much more in detail on this. I think this is a first step, and I really appreciate Marnie, you spending the afternoon with us. Maybe in this last minute, Rebecca or Joanna, can you show us the results of the survey? So we asked folks whether they had already taken an IAT, and only 1/3. So I will definitely propose then to our leadership here that I think that is a reasonable thing for us as program directors to plan to take this. Question 2, had you already taken a course at our own institution? And a lot have, and I think probably in the wake of this year, I think there were offerings as part of either Grand Rounds or some school of medicine based thing. Have you required our trainees? I think that's an immediate step perhaps that we can all take. I think certainly what is good for us as faculty and program directors will be also good for the trainees. It looks like only that same percentage, only 1/3 have asked to. Have faculty been required? That's usually either a departmental, school of medicine, or hospital-based thing, looks like about half. And if this becomes a standard part of the trainee curriculum or the faculty curriculum, how often should it be done? And it looks like folks are voting to do this annually. I think this will reassure certainly the constituent groups of both applicants, trainees, recruits, faculty, everyone that we are thinking about this. And I think that those are some important messages. Okay, with that, Marnie, thank you for that wonderful keynote portion to this and instilling a lot of discussion and answering all those questions. And thanks again for your time. So a little virtual round of applause for Marnie.
Thank you so much for having me.